Good afternoon, and thank you so much for joining us. My name is Maya Manion, and I'm the Faculty Director of the Health Law and Policy Program and Professor of Law at American University Washington College of Law. Thank you so much for joining us for our Future of Healthcare series and for this webinar on navigating the politicization of reproductive health. Our Future of Healthcare series features a series of panel discussions that examine trends, challenges, and opportunities in healthcare and health law and policy, highlighting both practitioner and scholar perspectives on a wide range of timely topics. This is the third year of the series, and we are delighted to have reached hundreds of attendees nationally and across industry sectors. We are co-hosting today's program with WCL's Gender Theory, Law, and Practice program, and we thank them for their support of today's webinar. We would also like to extend our deepest thanks to our terrific Future of Healthcare series partners, AHLA and ASLME. The American Health Law Association is the nation's largest nonpartisan 501c3 educational organization devoted to legal issues in the healthcare field. AHLA maintains excellence in health law by educating and connecting the health law community. We're also thrilled that our very own Health Law and Policy Program Director, Asha Shelzo, is serving as the current president of AHLA. We also want to thank our other partner, the American Society of Law, Medicine, and Ethics. ASLME is a nonprofit educational organization whose mission is to provide high-quality scholarship, debate, and critical thought for professionals working at the intersection of law, medicine, and ethics. And the support of both AHLA and ASLME is vital to our program's success, and we are deeply grateful for their continued partnership. I am really excited about today's important program, which will identify the ways in which reproductive health is harmed by political attacks working to override evidence-based practices, to undermine standards of care, and to control provider-patient decisions. Our distinguished panelists today will discuss the interconnected politicization of legislation, regulation, and litigation, and importantly discuss strategies for how lawyers can work to strengthen and improve healthcare delivery and health outcomes in our currently quite challenging political and legal landscape. Just a few administrative notes before we begin. Please note that live captioning is available and that this event is being recorded. The recording will be made available on the Health Law and Policy Program's Future of Healthcare website. It's my pleasure now to introduce Washington College of Law professor Jamille Abrams, who organized this webinar. We're very thankful for her leadership in organizing this discussion. Thank you so much, Jamie.
Thanks, Maya. Welcome, everyone. I'm so grateful to all of our attendees. I had to put my notes blocking the attendee names because I was so distracted with excitement as I saw it, folks. I know we have a wonderful audience today of scholars, researchers, teachers, students, and we're really excited to bring to you an important topic. We know it's a fast-paced news cycle. There is a dizzying number of attacks on women, on LGBTQ people, on people of color, attacks on science, health, data, expertise. So we are extra grateful that you have devoted your time this afternoon and this morning, wherever you are, to be with us. Our topic, the politicization of reproductive health, is both a current event, but also an enduring one. We know that the political overtones are new, the political attacks are deeper than ever, but we know that politicization of health is not new to our political systems, from bringing pills to the market, from HIV politics, from healthcare coverage. This is an enduring topic. And so we're hoping today that we can bring those historical threads through and bring a real crisp vision to where we are today. I am so excited to introduce you to our three speakers. These are folks who give me hope and inspiration and grounding in really uncertain times. And so I hope that they'll do the same for you today. Our first speaker is Liz Kukura. Liz explores the intersections of health law and gender with a focus on reproductive health and the politics of childbirth. She examines laws and policies that impact healthcare decision-making and the role of race, class, gender, and sexuality in shaping healthcare outcomes and healthcare access and experiences. Her work on obstetric violence particularly explores the lack of legal recourse for rights violations that occur during childbirth and the disproportionate burdens on people of color and other marginalized communities in the maternal care systems. Her scholarship has appeared in the Georgetown Law Review, Nebraska Law Review, Penn State Law Review, Baltimore Law Review, Berkeley Journal of Law, Gender Law and Justice, and her most recent work, Better Birth, is forthcoming in the Temple Law Review, and it explores the unduly burdensome regulations on midwifery care and how that impedes access to maternal health outcomes. So that's our first speaker. Next, Jamille Fields Allsbrook joins us. She recently joined St. Louis University School of Law in 2023 after a decades-long career in Washington, D.C., with experience in both the federal government and various nonprofit organizations focused on reproductive health, rights, and justice, and healthcare reform and finance. Most recently, Jamille has served as the senior policy advisor in the Office of Population Affairs in the HHS department. The Office of Population Affairs administers around $400 million of grants annually, including the Title X Family Planning Program. She was also the Director of Women's Health and Rights at the Center for American Progress, where she managed policy development, advised lawmakers, and conducted research and analysis. She's also held positions at National Planned Parenthood, National Health Law Program, where she was an If, When, How Reproductive Justice Fellow. And she's been an adjunct professor at the University of Maryland and the Harvard Center, a fellowship at the Harvard Center for Health Law and Policy Innovation. And then last but not least, we're joined by Karina Heckert. Karina is a medical anthropologist, and she is researching global health, maternal health, gender and sexuality, immigration, and ethnographic research methods. She has been funded by the National Science Foundation, the Wenner-Gren Foundation, the Latino Center for Leadership Development at SMU. Her research focuses on how policies shape illness experiences and experiences seeking healthcare. Her first book, Fault Lines of Care, Gender, HIV, and Global Health in Bolivia, published with Rutgers University Press, focused on how the system of HIV care itself generates gaps in who accesses services and under what circumstances and the ways that people experience care, stay in care, fall out of care, or avoid care. Now she's exploring the ways policies generate maternal harms for Latinas in the US-Mexico border region during pregnancy, birth, and postpartum period. The border city of El Paso, Texas, where she resides, has experienced overlapping socio-political crises related to the enactment of immigration and border policies, one of the deadliest mass shootings on U.S. soil, a COVID-19 death rate that was significantly higher than other major cities. So her work explores how these crises became embodied through various forms of maternal harm and are captured in her recent book, published in 2024 with the NYU Press, Birth in Times of Despair. Reproductive violence on the US-Mexico border. So we've got some great speakers, and we're really excited to get into conversation with you today. So let's get started. And what really excited me the most about bringing the three of you together particularly is the way in which your work simultaneously captures the systemic levels of what's happening, but also the on the ground human and community experiences of how laws and policies shape reproductive health. So symbolically in this moment, as we're all feeling dizzied and trying to hold on to something, I want to start with an example from your work of how reproductive health of individuals or communities are affected in obvious or non-obvious ways by the laws that surround us. So let's sort of bring to the ground how laws and policies affect reproductive health. And Liz, let's start with you, and then we'll have Karina go next.
Great. Thank you so much, Jamie. And thank you for organizing this. You are such a wonderful bringer together of people and always bring such infectious enthusiasm to any conversation that you're part of. So I appreciate that, as well as the invitation to join you all today. To the question, the immediate example that comes to mind for me is the relationship between the legal status of midwives and perinatal health outcomes. So meaning every state regulates midwives. How they do so impacts the choices that pregnant people have about where and how to deliver their babies, and this has a direct impact on maternal and infant health outcomes. In modern times, right, there are a couple different paths to becoming a midwife. In modern times, many midwives come to midwifery through nursing. They get the certified nurse midwife credential, and that enables them to be licensed in all 50 states. Other midwives come to midwifery directly without a background in nursing. They're called direct entry midwives, and may receive one of two different credentials, the certified professional midwife or the certified midwife. CMs, certified midwives, can attend births in both hospital and community settings, meaning at home or in freestanding birth centers. And CPMs, the certified professional midwives, they only attend birth in community settings outside the hospital. So for those direct entry midwives, only 38 states plus DC recognized CPMs through licensure or similar structure, and only 11 states plus DC licensed the certified midwives. So there are a significant number of states that limit the ability of direct entry midwives to practice legally in the state. And then beyond licensure, states impose a whole host of other types of restrictions on midwives, including things like the requirement that they be supervised by physicians and enter into a collaborative agreement. They have limitations on prescriptive authority, restrictions on where they can attend births. And so whether midwives can practice legally in a particular state and whether they're able to practice to the full extent of their education and training under the applicable state regulatory framework determines how meaningfully midwives are actually integrated into a particular state's maternity care system. And research shows us that with greater midwifery integration, we see better perinatal health outcomes, higher rates of vaginal delivery, of VBAC, vaginal birth after cesarean, higher rates of breastfeeding, and also lower rates of cesarean, lower rates of preterm birth, low birth weight infants, and neonatal death. So the regulatory details can be complex and a little wonky sometimes, but the relationship to the health of individuals and communities is really clear.
Great, thank you. Karina?
Thank you so much for your response, Liz, and thank you, Jamie, for inviting me to be a part of this conversation. To answer the question, I want to start with a story about Anessa, a woman who I interviewed back in 2022. But to understand her story, first, it's important to explain the differences between Medicaid for pregnant women and CHIP perinatal. So both programs in Texas are safety net programs to cover prenatal care and delivery, and to some extent postpartum care. Medicaid for pregnant women is much more comprehensive, and however, in Texas, you can only qualify for Medicaid for pregnant women if you have at least 5 years of legal permanent residency or are a U.S. citizen. CHIP perinatal in Texas captures people excluded from Medicaid due to the immigration requirements. So it's disproportionately covering precariously documented and undocumented populations and recent arrivals. And so CHIP perinatal uses funds through the Children's Health Insurance Program. The federal language has now switched to calling it the from conception to end of pregnancy option. Texas still maintains this unborn child option language, which really reflects that in Texas, the aim of CHIP perinatal has always been to cover the fetus and not necessarily the pregnant person. So Anessa had coverage under CHIP perinatal. She was in the process of adjusting her status through marriage to a U.S. citizen. So she did have a pathway to residency and citizenship. However, the context of the pandemic delayed the processing of that application. And so her coverage under CHIP perinatal, it covered her prenatal care, it covered the delivery. Postpartum, she began to develop mastitis, which is a bacterial infection that is fairly common among lactating people. She had a delay in being able to get an appointment with her provider because during the delivery, she tested positive for COVID, so no one would see her until she passed the 2-week postpartum point. By the time she went to her follow-up visit, which is, the one postpartum visit that was covered under CHIP perinatal, at that appointment, she was told that she screened positive for postpartum depression, which she did not have any referral for because her CHIP perinatal would not cover that. And she was also, told that she had mastitis, which she knew, but that CHIP perinatal would not cover the care that she needed for the mastitis. She was referred to the emergency room where hypothetically it could have been covered under emergency Medicaid. But it appears that, whoever was admitting her and evaluating her did not deem it a life-threatening emergency, so emergency Medicaid was not going to kick in. She was not given any information about other programs that she could apply for coverage, so she left thinking that she just didn't have any way to treat the mastitis. As the mastitis progressed, she knew she needed some care. So she finally crossed into Juarez, Mexico. So, El Paso is directly across the border from Juarez, Mexico. Mexico really serves as a safety net in many cases when people do not have access on the US side. And so Anessa, at the time, while in the process of adjusting her status, she was very fearful about being able to cross the border. She still had an active border crossing card, which enabled her to cross, but technically she could have been denied re-entry because she had overstayed that. However, that's not really very well tracked, given the daily flows of people crossing the US-Mexico border on the pedestrian bridges. So she was allowed back into the United States, but so she sought care in Juarez for the mastitis. By the time she was able to get care for it, it required surgical drainage of multiple abscesses. In the meantime, she was not able to breastfeed. Upon recovery from the mastitis, she was never able to reinitiate breastfeeding, which she feels like exacerbated the postpartum depression that she also never got follow-up care for. So her story really emphasizes the ways that, stratification to access to health services based on immigration status limits access to postpartum care especially, but also other types of care that people need during pregnancy. And, and in her case, the end result was she could no longer breastfeed, which was very important for her. And she never really got appropriate follow-up for her postpartum depression. And, she's just one example of, these are things that don't really register anywhere. Because she got the follow-up care in Juarez, none of that's documented well in her medical records even. And so it becomes very easy to ignore, what I found to be a pervasive pattern just because it's not documented in the places that matter.
Great, thank you. Jamille?
Hello, everybody. I just want to echo my thanks also for the invitation from Jamie to participate alongside Liz and Karina, whose work I've admired from afar. So just picking up on our the sort of the maternal health theme that both Karina and Liz have highlighted, I want to highlight a recent project I just completed entitled Regulating Birth Justice, where I try to outline the potential for administrative actions to improve maternal health. And I want to bring it up in this context because I think it's a example, though not a limited, not comprehensive, just an example of how I think some often overlooked laws and policies impact health. So as folks, many of you all on the call know, especially Liz, there's this burgeoning birth justice movement that has gained momentum in recent years. In particular, midwives and doulas and other perinatal workers have largely coined the term birth justice. And as was mentioned, I was an advocate before academic. And I think among the advocacy community, there seemed to be a recognition of the need of a movement that focuses on pregnancy and childbirth, particularly for Black and Indigenous women who have the worst outcomes. And I won't go all into it, but, it's largely a component of reproductive justice, this idea around people being able to decide if if, when, and how to become a parent or pregnant, and how to parent. And I offer that as just sort of a context and a goal, I think, about what the law and policy should be aiming to achieve. And the end of that story is that the U.S. is far from advancing birth justice in the ways that we implement our laws. Notably, the CDC has noted that 80% of deaths are preventable, maternal deaths are preventable, which suggests to me that there are policies and practices contributing to these deaths that just don't have to be. So, there's a number of complicating intersecting factors that lead us to this maternal health crisis. But one consistency, I think, is that the same women who have had the worst maternal health outcomes are the same people where government policies have treated them as unworthy to mother. In particular, Black women during slavery have been used as tools to experiment upon and advance the field of reproductive care, all the while being denied reproductive autonomy themselves. And once they were no longer seen as profitable commodities, society and the government began to discourage and even actively sought to prevent Black women from becoming mothers. At times, we have a history of forced sterilizations or otherwise sterilizations without consent. There's also been the systemic government erasure of Native Americans, and that has the inhibiting Indigenous women's reproductive autonomy also benefited from sort of inhibiting their decisions around childbirth. The Indian Health Service also has been accused of forcibly sterilizing thousands of women. Beyond sterilizations, we've seen, welfare policies that have restricted financial assistance if a person has more than a state-sanctioned number of children, Medicaid policies that have paid for insertion of long-acting reversible contraceptives while denying removal, and the systemic discouraging and forcing out of practice of traditional birthing practices such as midwifery and doula, which Liz raised. And so I offer that just as a historical context that, and because I think that legacy largely continues in our laws today. The healthcare system largely doesn't hold providers accountable for discrimination, incentivizes unnecessary and at times dangerous care, and systemically limits access to certain providers and birthing support, such as midwives and doulas. On a positive note, I think that well, maybe it's not that positive, but because the government has engaged in perpetuating birth injustices, I think that it also follows that the government has a responsibility and the tools to advance birth justice. Just like reproductive justice, I don't think the goal of birth justice is changing the law. However, I think there can be tools that are available to advance the cause. So, for example, this point about no accountability for discriminatory care, the federal government could stop paying for low-quality discriminatory care, which it does through federal financial assistance provided to hospitals, for example. Hospitals have to adhere to something known as conditions of participation. And recently, HHS had finalized a rule setting out specific requirements around maternal health. But even without those specific standards, there has long been standards around people having freedom of decision-making in their care and being free from abuse and coercion. And I think robust enforcement could help it prevent some of that behavior. The ACA's has a provision known as Section 1557 or non-discrimination provision, as some might know it as. And I think it could also be a tool about holding providers accountable. Folks might have seen and news coverage around HHS reaching a settlement with Cedars-Sinai out in California over the death of Kiara Johnson, and there the HHS have opened up an investigation into the hospital for its seemingly mistreatment of people of color compared to white women in their birthing and labor, and the family is while I said that an agreement has been reached where the hospital has agreed to make certain changes. The family has been calling for more, and I think both in that situation and beyond, that's a tool that HHS could be using to again discourage such discriminatory behavior. And then last thing I'll mention, just in the interest of time, I think we still largely pay for quantity over quality in our healthcare system, which leads to perverse payment incentives and some people sort of increased payments and unnecessary C-section, I think, where you get more money for delivering unnecessary care than you do for delivering higher quality care. And we've seen advancements in alternative payment models to help address some of that. So I'll stop there. But I think there's a lot that has been done on the negative side. So that means there's a lot that could be done on the positive.
Great. Thank you all. There's so many threads to follow in that. We heard about access barriers to entry, licensure, who's delivering care. We heard some important gaps in legislative approaches and funding issues. We've heard about some enforcement tools, litigation tools. We've heard some historical context, and we've lifted up a couple stories, both Kiara and Anessa. So really, so many threads for us to follow in our discussion. Jamille, let me stick with you for a moment, and I'd love to draw upon your work in the federal government. So your work, you've worked with both the legislative branch and administrative agencies, particularly in implementing federal grants that shape reproductive health. And so, our news cycles are filled with our budget deadline looming next week, and story after story of this very crude and crass slashing of federal programs and federal workers. And so I'd love for you to zoom us in. What are you watching in terms of federal funding, and what threats are out there with respect to federal funding domestically, and what would the effects be should we lose this federal funding on communities?
Yeah, thank you for that question, because I often think that I teach this class on healthcare finance, and I think my students sometimes are curious about, sort of given my background, what led me into thinking about like federal funding. It seems so not it may not be the sexiest topic, but it actually has a significant impact on healthcare and particularly on our reproductive healthcare. So a few things I'll highlight that I'm watching. One specific related to sort of my time in the federal government. As folks might recall, we have a program known as Title X, which is the only federal family planning program. It provides a range of services, including cervical cancer screenings, STI screening and counseling, pregnancy counseling, and contraceptives for people with lower income, people who are uninsured. It also provides access, to people who might not want to use their coverage because they don't want their parents to know, or they don't want their husband to know, or people who fall into some gaps around immigration. And so under the first time Trump administration, they imposed some very strict physical and financial separation upon abortion and related services. And as a result, nearly 50% of the network left the program. And that means that a significant portion of people lost access to be able to go to these health centers. And I should just say, context, the way Title X functions is it provides grants to nonprofit organizations, including a number of family planning providers, and as well as state and local governments and public health departments. So it's significant loss to have many of those grantees leave the program. When I was in HHS, it was very clear to me that even after shifting in policy under the Biden administration, the program was still being very much rebuilt. And right now, I am very concerned that the administration will come in and do a similar, if not worse, implementation of the program and lead to, again, a loss in the network framework at a time when, quite frankly, it hadn't regained from before. I think, folks might not fully appreciate that, when you lose a significant amount of funding like that at a health center, you might close the health center, people might get laid off, and that just doesn't come back with a change of administration and a change of policy. The program was already historically underfunded and flat funded across administrations and Congress. And so that is one concern. I'll quickly mention, I'm sure it's on a lot of folks' radar, the gutting of the Medicaid program. I think very, very much a concern that Congress will use this budget resolution that was passed just last week to try to advance a block granting or a per capita cap program, which, and just to quickly say, means that it would move the Medicaid program from an entitlement program to one that doesn't fluctuate based off of need, which is what the program does now, and instead gives a block set of money or a set of money based off of the enrollees. Despite promises, I don't believe those promises that they won't cut Medicaid. $880 billion they are trying to save over a 10-year period, and the math just isn't mathing, as the kids would say, to achieve that without cutting Medicaid. And I bring it up in this context because I think folks might not appreciate that I think this is a reproductive health, reproductive justice issue. 40% of pregnancies are funded by Medicaid. It's the largest public funder of family planning services. So any states will have to balance their budget and have to make funding cuts in order to because of the change in the structure of the program. That means things like optional services, such as the extending of Medicaid postpartum coverage, could, I think, be on the chopping block. States largely set physician reimbursements, including to OBGYNs, and it's already dangerously low. And then the last thing that two things quickly, and I won't unpack them much unless folks have questions, but I think there's also, we could see administrative actions that might not look like a funding cut, but very much is. Medicaid work requirements. For instance, most people on Medicaid do work, except for, and a lot of times people who don't are disproportionately women because they're taking care of home and family. And then the other thing I'm watchful about is what could happen or might happen with the birth control benefit. Folks might know the ACA requires most plans to cover a full range of FDA-approved contraceptives with no cost sharing. That's largely a creation of the administration. And so, I have lots of things I'm worried about, but I'll stop there.
No, thank you so much. That gives us a lot to keep our eye out in these news cycles. Karina, let me turn to you next. So building off of Jamille's commentary about the sort of harms that might flow from steep federal cuts, the two things that stand out to me most about your work are your work sort of shows the physiological effects of laws and policies on the bodies of pregnant and birthing people. And so we might hear in the news these very acute stories of crisis and harm, but the news cycles don't pick up as much the systemic and entrenched ways in which laws and policies affect the bodies of communities. And your work is really great at drawing that out, and further drawing out that even just the disruption and the misinformation. So even before we get to some of the concrete cuts that Jamille's describing, just the news cycles talking about disruption and fears of disruption or immigration enforcement are enough to already start to cut off services. So can you talk a little bit about this deeper effect of how these laws and policies and cuts will affect the bodies and lives of pregnant people?
Yes, definitely. So in thinking about kind of just the fears that people have, the clearest example of this really comes through people's perceptions of using CHIP perinatal. So when I first started my current research back in 2018, we were in Trump version 1. And during that period of time, the Trump administration announced proposed changes to the likely public charge rule. So the likely public charge rule has never been super clearly defined, but kind of administratively, the instructions to USCIS officials for determining if someone is a likely public charge is just, are they deemed likely to use public benefits? And if so, that can be grounds for denial of an adjustment of status, of an application for permanent residency, of an application for naturalization. And so, historically, there have always been some fears around using publicly funded benefits, but there was always kind of this protection around using health benefits and food benefits because those are non-cash benefits. With the proposed changes to the likely public charge rules starting in 2018, initially it was brought up, okay, those are programs, CHIP perinatal, WIC, usage of those programs could potentially deem someone a likely public charge. Now, the issue here was it took a full year or nearly a year of, debate on kind of the executive how that would be executed, the new guidelines for the likely public charge rule. During that period of time, people just didn't know what it was going to look like. And when the new rules surrounding the likely public charge went into effect in 2019, it still maintained protection for using CHIP perinatal and WIC. But that year where, okay, there was a question of, okay, what are the implications if I use this program? What I saw was, people who qualified for WIC and CHIP perinatal, but, in the future hope to be able to adjust their status or hope to naturalize. They were completely fearful of using that program. So they avoided, prenatal care through CHIP perinatal. Instead, they maybe pieced together some appointments at community clinics and then delivered under emergency Medicaid. And so there were a lot more limitations than on the ways people were using prenatal care, actively deciding not to use WIC. And so not having that additional access to nutritional support because of those fears. When the changes did go into effect in 2019, I think this did start to alleviate some fears for some people. For some people, those fears still lingered and did make some people still more reluctant to use these programs. But now we're shifting back to, I haven't heard renewed threats in kind of revamping the likely public charge rule, but I think it's on people's minds, and people are very fearful of, using public benefits that they are legally entitled to, regardless of their immigration status, over fears of what that could mean for them in the future. And then another issue where there was a lot of confusion in Texas was during the public health emergency, there was the extended Medicaid. So states could not disenroll people from Medicaid. So someone who had qualified for Medicaid coverage by virtue of pregnancy, they should have maintained that coverage until the end of the public health emergency in the spring of 2023. What I consistently started hearing from people was they assumed that their Medicaid coverage was expiring 2 months postpartum, like it always had been prior to the Medicaid extension. And it turned out that Health and Human Services was continuing to send people renewal packets with an expiration date that, matched that 2 months postpartum period. They weren't actually disenrolling anybody. Part of this might have just been a bureaucratic error where they continued to send out notifications that people had received in the past. But the effect was was people thought they were being dropped from Medicaid, and they didn't question it because prior to the public health emergency, that's when their Medicaid would have expired, was postpartum. And so a lot of people just didn't know that they actually should have been maintaining the coverage, and that they did maintain the coverage. And so they began to respond to their health needs like they were uninsured. If you get this notice saying your expiration date's coming up and you think your coverage is expiring, then you just respond like you don't have insurance. And so, people were avoiding care even though they thought maybe they should see a doctor for something, or crossing to Mexico for something that could have been covered in the United States.
Great, thank you, Karina. Liz, I want to turn to you now and talking about how all of what we're discussing affects standards of care. So your work is so incredibly powerful at lifting up how laws and policies affect how we train doctors, what pregnant and birthing people expect from their providers, the kind of relief that's available to pregnant people if they are harmed. And so I want to carry this conversation into the legal system and think about what work or gaps might exist in our legal system in what kinds of harms we define as sort of worthy of medical care at all, what harms we define as legally actionable, who we define as deserving of relief for harms. And we've heard some threads about that today. And so can you talk to us about how the legal system what role the legal system plays filling, responding to harms when they do occur?
Yeah, thanks. That's such a juicy question. There are lots of different ways to answer it. I think one place where we see this phenomenon clearly and instructively, perhaps, is in the mistreatment of women by their healthcare providers during childbirth. So some good recent research suggests that about 1 in 6 women experience mistreatment during the perinatal period, and we often refer to this as obstetric violence. Obstetric violence can include both physical and emotional or psychological harm, and it can range in severity and type of conduct, including abuse, coercion, and other disrespectful or dehumanizing conduct. So this might look like forced or unconsented medical interventions during labor and delivery, the use of physical force to restrain someone during delivery, to keep somebody on her back while she is pushing out her baby. It might look like threats to withhold treatment or to seek a court order compelling treatment, or to report somebody to a child welfare agency for declining an intervention that a doctor recommends. Or it could look like ignoring somebody, scolding somebody, or shaming somebody for reasons related to their identity, their health status, or even how they exercise their right to make their own medical decisions. So in recent years, we've seen a growing number of women come forward to talk about mistreatment that they experience at the hands of their healthcare providers during childbirth. But what we see pretty consistently is that when women turn to the legal system for accountability, to sue, to bring claims against their healthcare provider who caused them this harm, they encounter a host of obstacles. And there have been very few successful legal claims for obstetric violence related harms. The reasons for this are really complex, but I'll sort of just name 3 of them because I think they help sort of help us see the constellation of what's going on here, and also make some connections to sort of other aspects of reproductive health and reproductive rights and justice, where we might see similar phenomena unfold in terms of the insufficiency of law's response to harm. So why are there so few successful claims for obstetric violence? Well, first, we see, respect for medical authority and judicial deference to doctors when doctors defend misconduct on the basis that it was medically necessary. This comes up in the context of forced or coerced interventions in particular, where a doctor says, it doesn't matter that she didn't consent to having a cesarean. We thought it was necessary at the time, and our medical judgment trumps all other concerns. So among the many problems with this is that patients and doctors may weigh risks differently. A patient may put more weight on the risks that having a cesarean will pose for future pregnancies, and might want to delay that decision and try to have a vaginal delivery. while a doctor might put more weight on the risk of getting sued. And that leads to a different calculation and a different recommendation. But unquestioning judicial deference to medical authority means that women's control over those decisions during childbirth takes a backseat to doctors, regardless of what is driving a doctor's recommendation or a doctor's preference for intervention at a particular time. The second thing to flag is the willingness of courts and society more generally, really, to dismiss women's pain and suffering related to childbirth as normal and as an accepted part of fulfilling their reproductive roles. When women speak up about a doctor's mistreatment, they're often told by other healthcare providers and sometimes by their own friends and family that all that really matters is that they have a healthy baby, and so they really don't have anything to complain about. So that stereotype of a good mother as somebody who is self-sacrificing of needs, of body, of health, all of that, makes the legal system deaf to this type of harm. And we can see this reflected, I think, clearly in some of your own work, Jamie, in the disparate treatment between women's harms and fetal harm, right? Fetal harm regularly draws high jury verdicts and settlement awards, and we don't see a corollary when it comes to birth injuries to women themselves. And I think that phenomenon is related to a broader tendency to disbelieve women's accounts of violence that they experience in general, which is, of course, well documented in the realm of sexual assault and intimate partner violence. And then the third thing that I think is an important piece of the puzzle here is the focus on the fetus in both obstetrics and in law. Sometimes, maybe often, to the exclusion of the health and legal rights of the pregnant person herself. And this has been a feature of obstetrics for some time, right, tracing back to the introduction of ultrasound technology as a way to visualize the fetus as if the fetus were separate from the person carrying the pregnancy. And the kind of fetal-centric decision-making we see, which is prioritizing risks, potential risks to the fetus over risks to the pregnant person. We see that both in medicine and law. That has only been strengthened by the Dobbs decision and the kinds of state laws that have been passed in the wake of that decision. All of this means it's very difficult for people who have suffered obstetric violence to find a lawyer who's willing to take their case. And if they do, they find that courts are skeptical of their claims, skeptical of their harm, their injuries. And this leaves big gaps in accountability for harms to birthing people at the hands of their healthcare providers. And I would argue this also signals to women and other birthing people that their injuries just aren't real or they don't matter, which is a kind of epistemic harm. It's harmful in and of itself.
Yeah. Thank you so much, Liz. We're starting to round out our time, so we're gonna do lightning rounds. So one question for all of you. Let's think a little bit here. We're talking about the politicization of reproductive health, and it seems that we really need to just pivot to talking about geographical differences, right? We're seeing a starkly divided so-called red states, blue states, states with abortion access, states that are hostile, restrictive of abortion. We've talked today about border states. We haven't yet talked, but I'll mention rural geographies. We've mentioned tribal lands. And so I wanted to just get some, do some issue spotting from each of you as to what are you watching in those geopolitical divergences? What are you, where do you see differences in healthcare systems, healthcare outcomes, and are you seeing this? Do you anticipate this worsening in our current political environment? And Karina, let's have you go first.
All right. Well, so being on the US-Mexico border, one thing we're very concerned about are border closures. During the COVID-19 pandemic, the pandemic served as a pretext for a 21-month closure of the border to non-essential travel. US citizens and to some extent permanent residents could still travel pretty freely across the border, but people with other types of visas were restricted from doing so. And as I've mentioned, Mexico really serves as a safety net for people who can cannot access things on the US side of the border. And even for people who cannot cross, there's still like sending people who can cross for medications. And so that provides a workaround for things that are otherwise restricted in Texas, including access to abortion medications. And so if the border is closed again for some reason, that is going to be extremely disruptive, not just for, accessing healthcare services, but, for people's everyday lives. People cross the border on a daily basis for a number of things. At UTEP, approximately 10% of our students cross the border every day from Juarez. I mean, that's the extent of the connection that we have to Mexico in this community.
Thank you. Jamille?
Great. So I'll also use my home as an example. So I'm sitting here in Missouri, folks might be aware that Missouri had a total ban on abortion. It was a trigger law that, as the moment that Roe was overturned, it went into effect. And just this past November, we saw at the same time voters voted overwhelmingly for Donald Trump as the person who put people in place to overturn Roe. He also voted for a reproductive freedom amendment. And I've over the course of several months, I've seen received a number of questions from reporters about how could these things be? How could the same set of people who voted for largely politicians who oppose reproductive freedom also vote for the reproductive freedom amendment? And I don't know, but I think there's a number of theories out there about why that is. And one that I said to some reporters, I think people vote for different multiple issues. People don't tend to vote for one issue. And also at the same time, I think there are some people who might have thought that they could protect their reproductive freedom and still vote for this lawmaker that they were fond of. And we've seen over the course of many months that just not be the case. And I think Missouri is a good example of where you can have a quote unquote positive law and still have it undermined in practice. And so, many months later, since November, we still see abortion access non-existent here in the States. That's because one, the state already had a number of problematic laws on the books, including requirements around ambulatory surgical centers that abortion providers had to adhere to, and that was just struck down a couple weeks ago. And then we see now just earlier this week, or last week, time is related me, but Planned Parenthood have submitted a complication plan to be able to provide medication abortion, and we see the state just sitting on it. So I get going on, but and we see the Attorney General and legislators still relentlessly trying to seek to block abortion access here. And so I think Missouri serves as a good example of where you see voters clearly expressing their will for reproductive freedom, but when you still have those same lawmakers and administrators of the public health of the health department still being able to undermine and also just sow confusion and people still not being able to access care.
Thank you, Liz.
Yeah, so I'm concerned about the impact of these kind of divergences on medical education and training, on the maternity care workforce, and on the kind of resulting fragmentation in terms of what care patients can access in different states and different parts of the country. We're already seeing a version of this with the decline in application rates for OB residencies in states that ban abortion, because medical students are choosing not to train in these locations. They perceive correctly that it will be hard, if not impossible, to achieve full competency in procedures that are needed for miscarriage management. And they may not want to practice in states that are going to interfere with their ability to provide the best possible care for their patients, right? So we might see, it would not be surprising to see that the fact that obstetricians are in the crosshairs with a lot of the abortion politics going on now. It's going to deter some people from going into that specialty. We already have a workforce shortage in maternity care, and it's projected to get worse over the next couple of decades. And then over time, as OBs sort themselves into those who are willing or unwilling to practice without abortion training and under state laws that prioritize a fetus over a pregnant person, that's going to impact the kind of care that pregnant people in abortion restrictive states can access, for their pregnancies, for, complications in pregnancy, and just for normal delivery and childbirth. And so I think there are a lot of implications there that stretch into all aspects of reproductive health.
Great, thank you all. I'm going to end with looking for the light here. So I'm going to hybrid my question and a question from Kelly Zimmerer in our Q&A. So if you're an attendee here and you've heard an incredibly robust conversation across geographies, across state law, federal law, courts, legislatures, where can we make a difference? So sort of two parts. What gives you hope right now? And second, where do you think folks who are attending could jump in? What would make a difference given this landscape that we've sketched out today? And let's start with Liz on this one.
Okay. You said one thing, three things. Keep your eye on the criminal law and go, if for law students, for young lawyers, right, get trained, because there's so many aspects of intersection between reproductive health and justice and the criminal law. Take hope in the way that people are engaging in grassroots, outside the system distribution of medication abortion to get people the care that they need without having to go through formal channels. It's a really beautiful form of mutual aid and a way to think about resistance. And three, there was a birth justice tribunal last year that was a symbolic people's tribunal for people who had experienced obstetric violence and obstetric racism to give testimony about their harms. And it was an alternative, right? We see these kind of obstacles, we see ways that the legal system is unresponsive. And it was a beautifully creative and imaginative way to think past those obstacles and to kind of dream of a future that looks the way we want it to look. And so finding projects like that to engage in and to take hope in, I think is really important at this point in time.
Thank you. Karina?
My previous research dealt with HIV, and part of that was centered around HIV activism. And so I've found myself recently thinking back to the lessons we learned from kind of some key historical moments in time with the HIV epidemic. And one thing that we see in this history is, the key role that lawyers had in pushing governments to make decisions to provide access to care for people living with HIV as the medications were becoming available, but still not accessible in many contexts. And in many countries, South Africa is a great example of this. It was, pressure from activists and strategic use of lawyers and legal cases to build up that demand. And so I feel like those lessons are very applicable to right now, and there are a lot of legal battles ahead. And so I feel like day to day it's important to think about how it's the cumulative effect of case after case that's going to help undo some of what's coming down the line and what's already come in the past 6 weeks.
Great. Jamille, no pressure, but the last word of hope for all of us.
Yes, I'll give two, just one on a defensive end and this other on a more visionary note. One is I think that we should all, as lawyers or experts, be doing our best to explain some of these complicated issues to the public and to the people. And when it seems like all decks are stacked against us, and every branch is stacked to not function properly, I think it's even more important that we focus on mobilizing mobilizing people and mobilizing people power. You know, there's that quote that I'll botch about, the only thing that has ever changed the world has been a small group of people trying to make a difference. And, I think back to in 2017, it seemed like we were all doomed for the Affordable Care Act to be repealed. And, we did a lot of work, and many of us on this call, about explaining to people what this meant to them. And even with, the presidency and both branches of government, we were able to push back against that. And I hope folks try to do the same. And then the other piece, I'll just say, it also answers a question in the chat, is I think we can't stop pushing a vision that we want for the world. I think it'd be very comfortable to get in the defensive posture, but we believe in a world where Black and Indigenous and trans and other people are able to live full, thriving lives. And we can't let the other side set the barrier where we won't talk about DEI and we won't push for better, because we know what we had already wasn't good enough. And so we need to push even further now.
Thank you so much. I hope our attendees can stick with us for just one more moment. We're going to bring Asha is going to join us and offer thanks. I want to I myself thank each of our panelists. I hope our attendees find our panelists as insightful and inspirational, and they give you as much hope as they give me. And I'm super grateful that you took your time today to share your expertise with us. Asha?
Absolutely. Thank you, Jamie. Your leadership in organizing this. So the thoughtfulness and the insights that everyone has shared is so fantastic. And thank you to our national audience tuning in on this very important topic. We'll also keep in mind that we have many more wonderful programs coming up. And for this program, I want to thank again the American Society of Law, Medicine, and Ethics, the American Health Law Association, the Gender Theory Law and Practice Program, also our fantastic program coordinators, Tamina Asif and Kaylin May, who helped put everything together. So looking ahead, if you just keep an eye on the chat, we're going to put a couple of links in for you quickly. We really try to have fantastic programming that's really going to be meaningful for the work you're doing. So March 20th, join us in person in DC or on Zoom for Public Health at a Crossroads, Strengthening Pandemic Preparedness and Lessons Learned from COVID-19. Many will remember this is the 5-year anniversary of the lockdowns, and we're going to talk about many topics, vaccines and other preparedness concepts, but also workforce. Many of you, I think, are aware of the many, many challenges that the healthcare workforce is facing. And so that's going to be an area that we're going to drill down at that program. March 25th in the afternoon, we're doing a coffee chat in person and Zoom with the author Jill Hasday on her book, We the Men, which is a fantastic book that explores how sidelining women's stories undercuts reform and perpetuates injustice. And last but not least, our full day symposium, annual symposium that we hold, it's going to be April 11th from 9 to 4:30. And this is going to be a fantastic topic that I think is going to be really relevant to your work. It's health law and advancing equitable access for care for youth. And so we're going to look at this, the youth issues across reproductive health, LGBTQ, mental health, and many other topics that intersect all around the youth of our country. So again, all of this information is in the chat. You can always look at our WCL Health Law website and find this easily, or reach out to me or any one of us here at the WCL Health Law program. Thank you again, Karina, Jamille, Liz, and Jamie, and also to our Faculty Director, Maya Mannion, for her leadership. We're going to go ahead and close out the Zoom. We'll leave the chat for about 30 seconds so you can capture those links, and we wish you a wonderful day.